Hello everybody. Today we are going to discuss about the dialysis disequilibrium syndrome. So this was the question which was asked in DRNB Critical Care Exam 2022. The question was describe dialysis disequilibrium syndrome and preventive strategies of contrast-induced AKI. So dialysis disequilibrium syndrome refers to the array of neurological manifestations that are seen during or following dialysis, primarily after new initiation of dialysis. However, it can also be seen in chronic dialysis patients who miss their regular dialysis treatment. This syndrome is thought to arise from the fluid shift during hemodialysis, causing cerebral edema and wide variety of neurological symptoms. In continuous renal replacement therapy, where fluid shift is limited, dialysis disequilibrium syndrome is rarely reported. So, the common risk factor that predisposes a patient to dialysis disequilibrium syndrome are listed as follows. So, first, hemodialysis treatment, that is high blood urea nitrogen for before initiation of dialysis. Extremes of age, children or elderly. Then, sudden change in dialysis regime. Pre-existing neurological disease such as stroke, malignant hypertension, head trauma, seizure disorder, presence of other condition causing cerebral edema, conditions causing increased permeability of blood-brain barrier. So first case of dialysis disequilibrium was reported in literature in 1962. The incidence of this syndrome is not clearly defined because of non-specific manifestation and difficulty in confirming the diagnosis, making it likely that dialysis disequilibrium syndrome is underreported. It is more likely to occur after rapid hemodialysis and in high-risk group. The overall incidence is believed to have decreased with time due to awareness of the condition and implementation of the preventive strategies. Dialysis disequilibrium syndrome has been recognized for more than half decade, but pathogenesis is not clearly understood. Below are the two commonly proposed theories. The reverse urea effect. Small solutes like urea are rapidly removed during hemodialysis, particularly in the setting of marked azotemia. So urea is usually considered as an ineffective osmol because of its free diffusion across the cell membrane. However, its natural diffusion lags behind the rapid removal from the serum during hemodialysis, creating transient osmotic gradient between plasma and the brain cell. This leads to the water shift into brain cell, uh, producing cerebral edema. So cerebral edema is further enhanced by adaptive increase in brain aquaporin channel and decrease of urea channel in advanced chronic kidney disease. Studies in the rat models of DDS demonstrated that brain to plasma urea gradient is increased after hemodialysis and was associated with increased brain water content. Now, intracerebral acidosis. Studies have shown that there is fall in intracellular pH in brain cell with concomitant carbon dioxide retention among patients after initiation of dialysis. So the fall in pH causes sodium and potassium that are bound to protein to dissociate, making them osmotically active. Additional contributing factor to intracellular acidosis are adaptive retention of brain organic osmolyte like glutamine, glutamate, taurine, and myoinositide. So retention of the osmolyte causes paradoxical fall in intracellular pH, leading to increased brain osmolality and brain cerebral edema. Now about history and physical exam. Symptoms are commonly seen in patients with high blood urea nitrogen, in patients with chronic kidney disease versus acute kidney injury, with aggressive urea removal after initial dialysis treatment. Most cases of DDS are mild and self-limited. Patient reporting headache, nausea, blurred vision, as well as other CNS symptoms such as restlessness and confusion. This symptom usually begins soon after initiation of dialysis and resolve within the hour in most cases. Some symptoms like dizziness, muscle cramp that occur towards the later part of the dialysis are also considered to be part of DDS. Rarely, dialysis disequilibrium syndrome can present as increased intraocular pressure. In severe cases, symptom can progress to seizure, somnolence, stupor, or coma, leading to mortality. Now, evaluation. Dialysis disequilibrium syndrome is the clinical diagnosis, and there is no specific lab testing or imaging. It remains dialysis of exclusion in suspected individual who develop symptom after initial dialysis and resumption of dialysis after period of non-compliance. Clinical condition causing similar manifestation should be considered as a part of differential diagnosis. Now about treatment and management. Management of the DDS is primarily aimed at prevention rather than treatment after the onset of symptoms. Once a patient develops symptoms below the measures are should be considered. That is initiate sodium remodeling. Regardless of severity, DDS is initially treated by modifying the dialysis prescription. This is done by changing sodium dialysate bath or engaging the changed prescription on dialysis out machine. The symptoms should resolve as quickly as within 30 minutes. Therefore, dialysis need not to be stopped. Residual symptom after modification of prescription and sodium remodeling can be treated symptomatically. However, if symptoms do not resolve with the treatment, it may be required to stop the dialysis occasionally to evaluate for other underlying causes of symptoms. Failure of sodium remodeling. In patients with the severe symptoms of DDS, despite sodium remodeling, a trial to decrease intracerebral pressure should be taken. Some experts suggest using 5 mm of 23% saline or 12.5 mg of intravenous mannitol to increase plasma osmolality and simultaneously decrease further osmotic shift. But these are based on anecdotal evidence and limited data. The addition of the urea to the dialysate has also been reported to allow for repeated and intensive dialysis session, avoiding potentially neurological problems. Modalities to prevent development of DDS include implementing a slow and gentle initial hemodialysis, limiting the clearance of urea to prevent development of osmotic gradient, increasing dialysate sodium level, and administration of osmotically active substance. Evidence-based guidelines are lacking, but most experts agree on gradual clearance of urea. For patients new to dialysis, short 2-hour session at 150 to 200 ml per minute or sustained low efficiency dialysis can be done, which can be followed by consequent dialysis session in the following days. Blood flow can be further increased to match the outpatient setting in successive treatment. Consideration should be given to inpatient initiation of dialysis in cases where blood urea nitrogen is more than 100 and in patients with neurological symptoms such as altered mental status or myopia. So, in patients who frequently miss dialysis, it is not always possible to repeatedly hospitalize them to initiate slow dialysis. Thus, the sodium modeling technique is used in such a patient. Some dialysis machines have sodium modeling capability, in which case linear and exponential feature can be utilized to prevent hypertonicity at the end of session. Now about differential diagnosis. Differential diagnosis of DDS include uremia, stroke, subdural hematoma, metabolic disturbance, drug-induced encephalopathy, or infection. Tests like EEG have been studied to improve diagnosis but have limited potential. MRI imaging, especially a diffusion-weighted image that help in evaluating brain water content, would be helpful to support the diagnosis. About prognosis, dialysis disequilibrium syndrome is usually self-limited with symptom resolving in short interval. The prognosis is generally favorable and dialysis does not need to be stopped in majority of cases. In severe cases, symptom can progress to seizure, somnolence, stupor, or coma, leading to death. The complication of dialysis disequilibrium syndrome include consequences from delay in recognition of condition and delay in implementing preventive strategy. In rare cases with progression of cerebral edema, The symptom can progress to severe neurological manifestations such as seizure, coma, death in severe cases. So, deterrence and the patient education. Dialysis disequilibrium syndrome refers to range of symptoms that may occur during dialysis, especially in patients in whom dialysis is initially started or who have missed frequent session of dialysis. It is believed to occur due to rapid clearance of substance such as urea that get accumulated in the blood. This can lead to imbalance in the level of the fluid inside the cell of the brain, causing swelling and the symptoms such as headache, nausea, restlessness, confusion, and in severe cases, seizure, coma, and death. Although uncommon with increasing awareness, dialysis disequilibrium syndrome can be uncomfortable and distressful to the patient. So, patients should be advised to report any symptom after dialysis is started so that preventive measures can be implemented. It is also important to educate patients and their families to maintain regular dialysis sessions to help minimize the risk of kidneys. Now about the contrast-induced kidney injury. Contrast-induced acute kidney injury was first defined by European Society of Urogenital Radiology in 2002. In the absence of surgery, nephrotoxic drug, and other factors, serum creatinine content increased by 25% compared to baseline value within 72 hours after intravenous administration of iodine contrast medium. So this is the pathogenesis of contrast-induced injury. That is on iodine contrast medium administration. There is there are direct cytotoxic effect, which leads to the renal tubular fluid uh, accumulation due to osmotic pressure, which leads to the increased vascular resistance, decreased blood flow, increased local pressure, direct cytotoxicity in renal tubular cell and vascular endothelial cell, which leads to the tubular injury. Then reactive oxygen species production and oxidative stress, which results into the impairment in the renal function and indirect effects like renal hemodynamic alteration, arterial vasoconstriction, like uh, this uh, like arterial vasoconstriction due to increased endothelin, adenosine, decreased prostaglandins, and decreased nitric oxide. So this leads to the medullary ischemia and reduce in GF, which lead to the prolonged ischemia in outer medulla. Now, the mechanism of toxic effect of iodinated contrast medium and their related reactive oxygen species. So this leads into the apoptosis. So oxidative stress induced by reactive oxygen species is a potent inducer of apoptosis, which lead to the calcium overload to ROS overproduction. Then pyroptosis, which activates strong inflammatory response. Then autophagy, that is selective removal of damaged mitochondria and protects cell from damage induced by excessive reactive oxygen species. Then mRNA, which regulate gene expression in post-transcription level by degrading target mRNA or inhibiting translation. Now, the risk factors are patient-related factor is elderly population, that is more than 60 years. Kidney related factor is high serum uric acid, that is more than or equal to 8. Then diabetes. Medication related risk factors are concurrent nephrotoxic drug and the metformin. Then the summary commonly used to approach for prevention and treatment of CAIN, that is hydration therapy, which improves the renal blood flow, diluting ICM, and reducing the renal angiotensin system and reducing secretion of antidiuretics. Then NAC, that is scavenger of free radical, vasodilation, precursor of glutathione synthesis, and inhibiting angiotensin converting enzyme. Then statin, it has a pleiotropic action, improving endothelial function, maintaining nitric oxide production, and reducing free radical formation through NADPH oxidase activity. Then SGLT2, it has anti-inflammatory and antioxidative properties. Vitamin C, it is a scavenger of oxygen-free radical. Theophylline is the adenosine receptor antagonist. Thank you, guys.